If you want to learn about everything that's actually available in terms of enhancement, you have to find someone like me who does all those things versus a cosmetic surgeon who only places implants. So if they don't talk about fat transfers, if they've never done one, augmentation with the implant is never going to be a once-in-a-lifetime phenomenon. So just so everybody listening understands that. If you get an implant placed, you're going to get another operation at some point.
I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 18 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. This week at Soberhead Podcast, we're sitting down with Dr. Robert Whitfield, a board-certified plastic surgeon specializing in explant surgery and breast implant illness. Known as the breast implant illness expert, due to his exceptional explant skills and holistic and scientific approach to healthcare, Dr. Robert joined us today to talk about all things implants, implant illness, and implant removal. He also dives into the root cause behind implant illness, chronic inflammation, and gives insight into how chronic inflammation is affecting your everyday life, what the causes could be, and more. Now, let's go to the episode. Here is something that is fascinating. A huge amount of people who watch this channel frequently are not subscribed. So I want to ask you a quick favor. When you subscribe, it helps us to make the show better, access to the world-leading experts, and ultimately bring you more value. All that I ask is for you to hit the subscribe button, and in return, I promise we will make Ayık Kafa better every day. So welcome to Soberhead, Dr. Robert Whitfield. This is an exciting time because many of my friends, women between the age of 30 to 60, let's say, they're all very interested into any type of a plastic surgery. But what you're focusing is something very, very serious. I've been listening to many of your podcasts. I did some research. I did read some studies. And you are, I think, America's best implant illness expert. And it's the first time ever I heard something called explant. So it was like, it's not we know we use implants, but we never talk about the explants for some reason. I have so many questions, but I don't even know where to start because it's a very, not complicated, but there's so many things around it. So maybe you can start with it. What is an implant disease? Illness?
Sure. Well, thank you for having me on. And I often get asked, how did I get involved with this, issue? And for my career, I did oncologic reconstructive surgery. So I took care of patients with head and neck cancer. I took care of patients with breast cancer, with sarcomas. And my focus was on reconstructive surgery. Because breast cancer is so prevalent around the world, that's the most frequently seen cancer, and that would be the most frequently seen reconstructive case we would do in plastic surgery. So for everybody listening, I get asked all the time, why are there so many implants used in reconstructive surgery? And if you're in the United States, we have over 350 million people. We're a very, very large country. In fact, if you're listening just for scope, I'm in Texas. You can fit Spain in Texas. So the population is spread out over this really large country. And once you get outside of large cities, you're in Istanbul with an incredibly large population. But as you get further and further away from densely populated cities and you're into smaller cities and or villages, you have to have access to care. So really, we're just talking about access to care. And if a woman has to have or chooses to have, after she's been explained the risks and benefits, a mastectomy, if you're not in an urban center, you're in a smaller area, you're probably going to have less options just because of the sophistication of not just the surgeon, but the hospital they're at. So they may not have all the tools I'm used to having, because when I did oncologic reconstruction, I had operating room microscopes, I had specially trained nurses. I had specially trained techs. I had intensive care units. I had nurses who understood the signs and symptoms if something was going wrong with one of the patients. So it's a very different type of care plan for somebody who's having microsurgery, which is what I did for a living, moving tissue from one area of the body like a transplant surgery, versus being in a smaller, maybe the city's 250,000 or 500,000 people or something smaller, and they're offered a reconstruction with an implant because that's what they can actually do and execute due to the sophistication of the hospital they're at or the care they're able to obtain in that area. So I think that's one kind of basic component. So that's always going to be done more frequently around the world. So everybody should just understand that. That's always going to be done more frequently just because of access. So in 2016, I had a patient come who had a reconstruction with an implant previously and wanted to go flat. And so flat is a form of care after mastectomy. It's a choice that's made by a growing number of patients. They simply have the tissue, excess tissue removed, so skin and or other subcutaneous tissue, and then a closure, which is a flat closure. And that's every woman's choice. And it's just in terms of workup, I had done her workup, and there was nothing specifically from a symptom standpoint or a finding standpoint on a MRI or anything that would be concerning. Her only symptom in retrospect, which we can talk about at the end, was fatigue. And many patients who undergo cancer treatments, chemotherapy treatments, suffer from fatigue. It's usually due to bone marrow suppression. So we took care of her actually in a hospital setting, and I removed all the scar tissue. So whether you have a hip, knee, breast, dental, cardiac, neurologic, whatever implant is ever placed in your body immediately forms a scar around it because your body knows that's foreign, so it creates a reaction. And we took all of that tissue out, which is customary when I did oncologic treatments, because in that tissue you can have recurrent cancer, so you send all that so the pathologist can look at it. And then I would always check it for infection because that's part of my training. And so I did that for this patient, and she fortunately had no evidence of recurrent cancer. But she did, on the examination looking for bacteria, have an E. coli infection. Now,
how does that happen, E. coli in the breast?
Right. So for everybody listening, that should be the question. Like, how does that specific infection happen, and why couldn't I see it with a blood test or with a in-person physical examination? And that's because it was locked inside the scar tissue up against the breast implant. And so normally that would show something typically in the blood, but in this patient it didn't. And so there are 3 ways to get an infection typically when you have an implant placed. So it doesn't matter what type of implant. Like I said, it could be a hip, breast, dental, cardiac, whatever. So that these happen 2 ways are in the operating room. So someone can open an implant in the operating room and hand it to the surgeon. In that opening process and delivery process, it's contaminated somehow. That's really, really low because of the way the things are packaged. And then the surgeon who places the implant, in the process of placing the implant, it can become contaminated. Those are also extremely low. So what's the third way? Well, the third way is the most common way you can get an infection in an implant. You, for instance, maybe get a cut on your skin and it gets inflamed and or infected. So the bacteria would get into the bloodstream, and that can attach to the surface of the implant. And then your body, because that's not your tissue, can't really get rid of that. Now, our body's very clever, and all day, every day, we have a surveillance system, our natural killer cells, and it helps clear cancer cells. It helps fight against infections. That's what our body does. It keeps all that in check. But if you were to have a urinary tract infection or like a cut on the skin that got infected or upper respiratory tract infection, those things could, in fact, contaminate an implant. And this has been known for many, many years. So it's not a new thing. So this patient had this problem. I placed her on the correct antibiotic therapy for this. And then magically, all of her fatigue resolved. So she had been walking around with this infection for I don't know how long. And so it was her case that, kind of started me on this journey. And she put me on social media in a private group and said I would do explant surgery. So I just had people start calling my office at that time and start asking for explant surgery and capsulectomies and things like that, which obviously was a little bit backwards, right? Because I was a surgeon who did reconstruction.
Were you just doing the cancer patient, or you were doing normal people too who wants to put implants?
Yeah, it was about 80% reconstruction, about 20% cosmetic. Always. My main practice has always been cancer reconstruction. So, I mean, from that period, and moving forward, that was in 2016. I gave testimony at the FDA hearings in the United States about breast implants and about breast implant illness. And as the president-elect of the Research Society, I said we would do our best to help fund research, for breast implant illness. That led to a couple papers being published. And one of them talked about different aspects of bacterial contamination, like I just described. And that paper reported about 48% bacterial contamination, which in my experience, that was too high. So I published a paper last September 24, of our experience at my clinic. And in almost 600 cases, the actual rate of bacterial contamination is 29% on PCR testing. So that's a lot of, explanation. So about, you can think of around a third of time that I explant somebody, I'll find some kind of contaminant. And it's not fungus, it's not mold. So I'll put that to bed. That's not the problem with this. It's bacteria.
It seems like one of the very common side effects of that is fatigue.
Right.
And that means like inflammation, I guess, infection. So can they not find any other doctor in their blood workup saying that there's that CRP is high or something?
Well, that's a great question. So we looked at CRP and said, over several years, and it doesn't change in these patients to a degree. So what happens, and there is actually research now to show what is happening, what's creating that problem. And the breast tissue, well, let's take a step back. So the scar tissue I talked about, it is not a shield. So the tissue of the breast can interact with the bacteria on the implant. And that interaction, the breast tissue specifically can interact, and there is a fatty acid in the breast tissue called oleic acid. Oleic acid can oxidize and become oxylipin 10-home. That can lead to what you're describing, which is fatigue. They can have more pain. So all the symptoms that is on the laundry list of symptoms associated with that, which you are rightfully referring to as chronic inflammatory symptoms, can be contributed to by oxylipin 10-home. And there are other oxylipins that are also able to contribute. Now, there is no specific blood test for oxylipin 10-home right now, but we're hopeful in the future there will be one.
As a percentage, let's say, how many of the people who are having an implant may end up with some sort of a complication? We kind of call this a complication, I guess. Kind of, not like an operation complication, but whatever it's causing it. And then, is there a time period? Is it like after 1 year, always from the beginning, or like over 10 years?
So that's a lot to unpack. And there's not going to be
Let's unpack.
One kind of special answer for that question. So in my experience, this is how I look at the problem. So I've been taking care of these patients since 2016. So we're in 2025. So I almost have a decade of taking care of this problem. And we know that of the explanted specimens, 29% have bacterial contamination. So 2.2 million implants are placed worldwide annually. If you just take it out 10 years, you've got over 20 million, roughly a third of those. So you're looking at like 6.6 million who could have bacterial contamination. And that's just a function of your genetics, your exposures, what you eat, what you drink, the air you breathe. You know, those are things that are a function of just our day-to-day lives.
Probably it starts at the beginning and then it kind of starts growing around the breast tissue.
No, I think just so we're clear, like I'll use this example. So if someone is tested for breast cancer genes, BRCA1, BRCA2, all of them do not develop breast cancer because there's incomplete penetrance. So that doesn't mean if someone tests positive, they're going to have breast cancer. That means they have to be watched, and their risk is, you know, probably 80% lifetime. If someone has Marfan syndrome, that's a different type of gene that has what's called variable expressivity. So that will have a whole spectrum of different phenotypes. So what decides one person's going to get cancer and what decides one person's going to have a different type of expression of a gene is a function of all those other things, right? You can't pick your parents and you can't outrun a bad diet. Our exposures, you know, just, I'm sure you already know this, like when you sleep well, you feel better. Right. So like my whole program, my book, everything I talk about is based on sleep. Because although I've operated for, you know, almost 30 years, taking care of patients, if they don't sleep well, eat well, be, you know, very mindful of what they're putting in their system, and we have a specific set of supplements we use, it gets really complicated for us to help them recover. And so your question is a good one, but your exposures will dictate most of this. And so just like I said, anybody with an implant should be informed that the implant can get infected, which of course they are. But then, you know, you have an implant placed, whether it's a knee, hip, breast, whatever, you just go about your life, right? You go back to what you do, and you probably just take for granted getting sick and recovering, or getting a cut and it healing. But all those things can contribute to exposure risks of an implant.
To be honest with you, when you said like people need to be informed, from me to anyone that I know, I don't think that none of us were informed.
What year did you get your implants done? How old were you?
It's been 15 years. So I was 38.
Well, so I think then that's a different conversation. So typically what I see is somebody got them between 18 and 25, and having a conversation between an 18 and a 25-year-old person, I think is very difficult. At an age you're describing, it should be easier to have the conversation, explain the risks and benefits, and you ask questions as well.
And also, you know, when I was listening to you, and to so many people it happens, including me, it's never one operation. Either it's too big or not symmetrical or too whatever, and then like right after, maybe a month later or 6 weeks later, you get into another operation, and then it's time to change it. So it seems like how you're describing in one of the talk that you were giving that, you know, over and over these operations, like you keep cutting yourself, basically. They cut you, and then your chance to be exposed to any type of an infection from outside is greater.
Right. Yeah. So, you know, obviously, I took care of cancer patients, and if you just look at the scientific literature over time, those patients always have more operations because they've had cancer and they have a reconstructive process to go through. When you're talking about a cosmetic case like you're referring to, the best time to do anything is the first time. Anytime after that, you're describing what I worry about most, which is an increased incidence of yet another problem, whether it's a scarring complication, an infection, an extrusion in the worst case scenarios with an implant. Malposition is very common. So I got very good at taking care of problems because I took care of patients with cancer who had frequent operations, or they may have had radiation therapy or chemotherapy or all these other things involved with them.
So is there any better type of an implant, or for you all of them kind of the same?
Yeah, I think all implants have the same inherent risks. I mean, like I said, if it's a knee implant for, you know, if you had arthritis of your knee and they, you know, after talking with you felt a knee replacement was best, you know, are there different types of knee implants? Yes. Are they going to change the outcome? Probably not significantly. It's still a foreign body. It's still got to be put in and cared for, and you're still at risk for all the same problems. So whether it's a saline implant or a silicone implant, one vendor or another vendor, over the last almost decade, I've taken out all those things, some from Europe. And, you know, it really doesn't matter based on what we just described. Anybody can get a problem with any type of implant, and is one, more susceptible than another. That didn't really rear its head in our examination of the data. I would say on a whole, I don't worry about it.
I also heard you saying that when the operation is done, or you have someone to do an explant and they had a previous explant as well, it's not like totally removed from the person, like the biofilm or something.
I've had to redo cases where they didn't have all of the capsule removed.
Yeah.
There was this dialogue going on about this and whether or not a capsule, should part of it be removed, should all of it be removed. And so I approach these all the same way because it's so frequently found in our experience that there is bacterial contamination and that leads to symptoms. We try to get all that material out at one time and just return everything back to normal. Are some cases easier versus others? Sure. And the question is it safe to do that? So in terms of our cases, in the first 1,000, we had very few complications. And there's not anything that should require a hospitalization when you're doing these. I think the best advice to give, people concerned about this part of the surgery is just go to somebody who's used to doing them. If that in your area is not easy, then you need to just go travel and have the discussion and see if that fits with what or aligns with what you want done.
What you're saying is that sometimes parts of the capsule is left inside?
When I do them, nothing's left
No,
inside.
no, I know you don't.
I've reoperated on patients
Uh-huh.
who've had capsule remain. So if you leave that and that person has biofilm, which we know is at least 29% of the time in our case studies versus 48% in others, you're just leaving bacterial contamination inside somebody that can lead to ongoing symptoms.
So, Dr. Whitfield, what do you think is the reason that they're leaving it? Because they don't know? Because you're a reconstructive surgeon. After cancer, patients need to be removed many dangerous parts of their body. So the regular operators that is doing this, like you said, rural areas, there's so many providers that they may not be skilled. Is it why they don't remove? Is it they didn't learn about it?
Yeah, I don't think they believe this is a real problem, and they don't believe that that's a necessary part of it. So if you're the patient and you're concerned about breast implant-associated lymphoma, you're concerned about bacterial infection, you have to advocate for yourself. If you've had multiple operations like you're describing, advocate for yourself to get the scar tissue removed, because you don't want to then, in 3 months or 3 years, have the same situation, not feel better.
What are the other symptoms that you're witnessing with people who have a breast implant illness?
Sure, that's a great question. So the most common symptoms are what you described, which are fatigue. Brain fog is a very common one. Muscle and joint pain, chest pressure, chest pain, shortness of breath. Sometimes people have palpitations. They have a host of just gut trouble that may, be an isolated thing or maybe in combination with other factors. They may have problems with intractable urinary tract infections, bacterial vaginosis, all sorts of other skin rashes and things can develop. So it's a whole constellation of things that are associated with chronic inflammation in their system.
Let's now come to what you're super skilled and famous on. So what is a proper explant surgery that you explained, but you're doing it differently? Yeah, you have a whole different method.
Well, programmatically, what we learned is people have a variety of exposures like we discussed earlier. So our program, SHARP, which I wrote a book about, really looks at your genetics because each of us inherits a certain set of genes from our parents, and those allow us to detoxify. If our detoxification, ability is exceeded or the bucket becomes too full and spills over, you get chronic inflammation symptoms. And that's what we see. So we do different tests to look for opportunities to help people. One of them is a toxicity burden test. So it's a urine test that looks at heavy metals, environmental toxins, mycotoxins, which are mold toxins. We do gut testing to look for things like SIBO, to look for fungal overgrowth, parasitic overgrowth. We do food sensitivity testing because a lot of people have triggers in their diet they just don't know about. We look at metabolism testing because we're trying to get better ideas about how their body's coping with inflammation, and those are not really, in our experience, found on the traditional CRP NSAID rate. So we're looking at different chemical reactions. And then, of course, we're looking at hormone balance. I have a lot of patients that come in with thyroid problems, estrogen, progesterone, testosterone imbalance, and that makes them feel, even at an early age, like they're going through menopause. They have maybe decreased energy levels or decreased libido just because everything is so off.
So basically, my understanding is that you're not only the surgeon, but you're looking holistically at the person's whole system.
We have a whole team that runs that part of the program. That's really a functional program to help people recover, but we don't try to do it after surgery. We're trying to work on it on the front end before you ever have treatment, trying to get people in a better state of wellness prior to the treatment, and then use the explant as a way to further enhance their ability really to recover, although that seems a little odd. But once you remove that, many people will do markedly better. The program then runs for the calendar year that they're taking care of with us, but also you can just run the program in perpetuity because it's set up as a wellness program.
So Dr. Whitfield, probably after what you said about these implants, you probably are not using external items.
Yeah, so we haven't used breast implants in our clinic in a long period of time. And so for everybody listening, there's primary augmentation, there's secondaries, there's revisions, there's a whole series of problems like you're describing with malposition and things that develop. So because I had an extensive experience with reconstructive surgery, I got very adept at taking care of the problems from cancer reconstruction with implants and from cosmetic treatment with implants. So when we were doing cases with implants, it was mostly the correct problems. And then about, it's almost 6 years ago now. So because we were doing so many explants, we just stopped correcting, other problems because it got to be frustrating for me to take care of all those other problems that were being created. I just felt it was easier to transition completely to taking care of explant patients. So that's all we focus on now.
And what are you using? Because you're taking the implant out. What are you putting instead, unless the person want to go flat?
Yeah, so for volume, to enhance the breast, we use the patient's own fat. But that goes back to running the Sharp method. Basically, what you want to do is get everybody in as healthy a position as possible, because you can use fat. Fat's used around the world for buttock augmentation, breast augmentation, facial rejuvenation, hand rejuvenation. Fat is the original filler, so you can use that. You just want to optimize the patient. So think of like when we're all in our 20s, if we can remember that far back. I'm getting old now. But
I'm there with you.
Everything worked extremely well. So I always have the same discussion with patients. The closer you are to 20, the easier everything is to do. The closer you are to 80, like I am now, it gets a little bit more challenging. So if we're going to do a fat transfer, we want to optimize the patient so that they're as healthy as possible or in the best position possible for success. But we use fat.
What does health to do with fat?
Well, you don't want somebody who's chronically inflamed having more surgery. Think of it holistically, and if you're trying to help them, you want to put them in a good position. So if you have someone come in with a lot of symptoms of chronic inflammation, their testing reveals a lot of toxicity, you want to help them with that before doing, say, the fat transfer. You can always do those later.
Where do you take the fat from if they don't have extra fat? You always find somewhere you take from different areas?
Yeah, so usually kind of the lower back, love handle area, inner thigh, outer thigh, the abdomens, those are usually the most common 4 places we would take fat from. What you're describing is the harder situation is like a really lean, thin patient. And that's the reason they got implants. So those are the most challenging folks. In some instances, you have to go pretty aggressively to get enough fat to help them, but you can.
So you're not using from outside?
No. No, this is the patient's own fat.
Yeah. In your operation technique, is there any difference than a regular breast augmentation process?
Yeah, the explant process is you're taking all the material out. So think of like a Fabergé egg or an Easter egg. You want to take it out undisturbed. You don't want to break the shell, especially if it was going to be one that was ruptured, potentially has cancer or is infected.
And then when you place the fat instead, I guess you are very cautious not to put back any bacteria inside because, you know, it's a cut open operation at the end of the day.
So the fat goes in a different plane. So you're not wearing a shirt with a pocket on the front, but I am. So mine would go in the pocket on the front of the shirt. So that's beneath the skin, but above the breast. You don't put it back where you took the implant out of.
Oh, okay.
That's not where fat belongs.
Okay. And then skin can carry that fat.
So it's just beneath the skin. If you were to examine us all after our skin had been taken off so you could see underneath the hood, so to speak, that's where the fat is.
I guess you're not using any drains.
I haven't used drains for several years, mostly because of fat transfers. So just think of anybody undergoing liposuction. So liposuction is the most common cosmetic treatment done worldwide.
Sure.
It's done by dermatologists, cosmetic surgeons, plastic surgeons. It's done all the time. People get liters of fluid placed in their tissues and they make tiny holes, 2 to 4 millimeters, and they take fat out, along with the fluid, of course. But a lot of that fluid remains, and nobody puts a drain tube in those patients to get the fluid out. So how does the fluid all magically come out? Your lymphatic system. So we just leverage the fact that your lymphatic system is going to remove the fluid. Typically, I connect the space of the breast pocket with the subcutaneous tissues of the abdominal wall or the flank, especially if I've done liposuction for fat harvest, for fat transfer. And that's basically how we avoid the use of drains. Drains do not eliminate the risk of a seroma, which is a fluid collection. They do not eliminate the risk of a hematoma, which is bleeding. And they do carry a risk of infection. That's obviously higher because it's a foreign device going in the body.
Okay, so liposuction you said, and I had my share on that too. My audience is now, I'm opening my private life to people, but my goal is to help people to have smarter choices. In order not to have these ondulation on where the fat is taking, people need to wear these special garments in a way to be able to make the skin flatter where the fat is taking. So is the person that you're taking the fat from, are you doing aftercare like 6 weeks wear that socks or something like that?
So there's a couple things. One, you shouldn't have undulations like you're describing. That's a technical aspect in the surgery. So that's how it was done. Two, we use a combination of liposuction compression and a lymphatic wear, kind of like instead of athletic wear, there's lymphatic wear, because we're really trying to promote lymphatic drainage. We also, in my office, have hyperbaric oxygen therapy. We have lymphatic massage devices from New Zealand called Flowpresso. You already heard I have a NanoVi, so while you're getting Flowpresso treatments, you're getting NanoVi treatments, and then we use red light as well as other modalities in our office.
Oh, so you're kind of speeding up the healing process in a way.
Yeah, you want to do everything you can to get people to recover faster. That's the whole part of our clinic. That's why people come from Europe and Asia and Australia.
How long do they stay when they come?
So if people are coming from out of the country, they stay about a month.
About a month. Wow. Before and after.
So they would arrive typically, on a long haul flight over, we'll say 6 hours. If you're just coming, direct from Heathrow, actually that's about an 8.5 hour flight. So I just have them come a couple of days earlier so they can acclimate, and then they stay 3 to 4 weeks after.
Why is that?
So we can take advantage of helping them and put them through hyperbaric and lymphatic massage and red light therapy in our clinic. Probably 0.0001% of the plastic surgery clinics in the world that have what I have.
I interviewed Dr. Chestnut, and he's kind of doing the similar things, I think, after his surgeries.
Yeah, he's a facial plastic surgeon. He's an ENT.
You know, hyperbaric, red light. That's really amazing. Now that we kind of unpacked that whole explant and you choose to put fat inside, many young people would want to, even though they're not flat, they want to augment their breast. Do you have a message? Something that they can learn from besides listening to this whole thing?
I think, you're talking about body image, and that's a whole different thing when you're younger. You're concerned about things relative to body image. And as you get older, like I am now, it's not so, important. When you're trying to discuss body image with a young person, that's a very complicated discussion because, one, they don't have much in the way of life experience because they haven't been alive that long. Now, I had discussions with patients about cancer. The youngest person I took care of with cancer was 24, with breast cancer, and have a mastectomy at 24. Now, you can imagine that's a very different discussion to have with a 24-year-old versus a cosmetic augmentation. I would answer it this way. If you want to learn about everything that's actually available in terms of enhancement, you have to find someone like me who does all those things versus a cosmetic surgeon who only places implants. So if they don't talk about fat transfers, if they've never done one, they don't have any examples of them in their, we'll say portfolio, I don't think that's a great person to go have a chat with. Because if they don't or won't or can't do it, why would they even talk about it? If you want to learn about everything that's actually available in terms of enhancement, you have to find someone like me who does all those things. I think versus a cosmetic surgeon who only places implants. So if they don't talk about fat transfers, if they've never done one, all the forms of enhancement, and fat transfer is one of the forms of enhancement. Augmentation with the implant is never going to be a once-in-a-lifetime phenomenon. So just so everybody listening understands that. If you get an implant placed, you're going to get another operation at some point for that implant. Doesn't matter what it is. Hip, knee, breast, dental. You know how many people I have to deal with who have infected root canals from a dental procedure? That's a big problem. So there's all sorts of issues with these things, and you just have to be mindful of them, Got to take care of everybody. If you're going to have something done, you want to have all the information to sit down and be able to make a decision.
Dr. Whitfield, so tell me, since when people are using fat instead of an external implant?
Fat transfers have been done for over 100 years. I've been using them since 2004.
But old medicine versus new medicine, really, it blows my mind because the first time that I had the breast operation, it was just for the lift. And instead of using techniques that you're telling, it was the best plastic surgeon in Turkey, it wasn't like just, and he was a microsurgeon. I'm sure he did so many things that you already say. They chose to use an implant rather trying to do something else. And the whole nightmare started like that. Instead of using fat and I was like in my mid-20s maybe. So I had enough fat around me, believe me. I didn't need.
So that's the discussion, right? That's exactly what we're talking about. So you had a specific idea in terms of options. You didn't get all the options. So for volume, there's fat, there's an implant. But if you already had volume, and say you had breastfed or went up and down in weight, you're talking about reshaping the breast and lifting the breast up.
Sure.
So you could do that and add fat. There's a lot of ways to do this. It just depends on who you're speaking to about it in terms of their skill set. So everybody's got a different set of skills and, what they have experience with, what they feel comfortable with, what the patient wants are all factors in what the ultimate decision is made about what is done.
Yeah, well, again, these episodes that I'm trying to share with my country to bring the latest or the safest method. So because people needs to be aware of these, when I was young, nor now, nobody told me. But you have also different nice stuff that you do in your clinic. We spoke all the nightmares that, like the bacteria, tiredness, inflammation, explant, be careful. But you're also having very nice methods to, use on the face?
Obviously, facelifting is never going to go away, just like breast augmentation is never going to go away. There are going to be people who require a facelift because that's a function of too much excess skin. I don't really take care of those patients anymore. I try to help patients with minimally invasive rejuvenation using what I term the no-cut facelift. It's a combination of technologies that are microcoring, which take skin out without scarring, things that use radiofrequency skin tightening, minimally invasive neck lifts, any kind of tool or modality that can be done with minimal access, very little, if no visible scarring is what I'm interested in.
I think it's great. So you choose to let people live in a better looking but a more natural way.
First of all, I don't like a lot of scarring. So that's just a personal preference. So, I think a facelift scar is one that's hard to hide. It's obvious when you see it. The appearance changes can be really obvious. So if I can help somebody avoid the scarring, then that makes me happy. That's what I want to try to do for them.
You're absolutely right. That's why probably I'm staying away from them. Not that I need now, but I'm freaking out about the scarrings.
Well, nobody wants scars.
Well, many people stay with scars.
You want to do everything you can to help without creating, more visible scarring.
Yeah, so you're in Austin.
I'm in Austin, Texas. Now everybody moves here, so...
I know. I was living in New York for 12 years before moving back to Turkey.
Okay.
And, since I moved back, this whole movement of longevity and biohacking is so crazy. I'm like, why it wasn't like this when I was living there? Now I have to fly across the ocean like every couple of months. So do you have any other office anywhere else for the listeners?
Currently, we're just in Austin in the United States.
Your website is?
Yeah, if you want to learn more about what we do, I have put together a podcast that basically just speaks about explant and recovery, as well as a YouTube channel just about explant and recovery. And then we have a book out called Sharp that details our methodology. And then, of course, you can just go to the website. All the resources are there, drrobertwhitfield.com. And then you'll be able to just take your time and go through things. Please don't rush. There's plenty of content to go ahead and go through and answer questions. And I'm happy to, hop on a video with folks who are unable to come to Austin. And if you're like Esra comes to Austin now for different meetings, we'll be able to see her in the spring.
Yeah, I hope so. Thank you so much, Dr. Whitfield. Thank you for your time. And I hope to see you in the spring.
All right.